Yes, ma'am. We can go live in 3, 2, 1, and we are live.
Good evening, everyone. We are here today again with yet another episode of the Soliloquy program that we at ISAR are conducting every month for you. And we are getting on board the most esteemed speakers to talk about the most most interesting topics in the field of assisted reproduction. And today we have
Ritu, ma'am,
Ritu,
you're on mute. Ma'am, you're
you're
on
on
mute.
mute, Ritu.
okay. Good evening, everyone. Welcome to yet another episode of the Soliloquy series that the ISAR, that is Indian Society of Assisted Reproduction, brings to you every month. And we have handpicked our speakers for this program. Today, we have a very interesting personality on board for this program, but I will not introduce him because that is something that I will ask Erica to do later on. Today, I am going to invite Dr. Amit Patki, sir, to start the program and to give his blessings for this program to go well. Thank you, sir.
A very good evening and welcome to yet another episode of Soliloquy series. This is a series which we wanted to do with one speaker, one topic, so that we can discuss it in great details and have all your questions and queries answered. I'm really happy that the conveners led by Ritu have really taken efforts to choose not only the best in India but international. And we have a very good speaker, the lab director of one of the most successful labs in the UAE. And as you all know, the lab director and the lab is the core of any success. So without wasting much time, I thank you for joining, and I take the opportunity to thank Dr. Abraham for having spent his time with us and discussing this rather trending topic. Over to you, Ritu.
Thank you, sir. I would now invite Dr. Asha Bakshi, madam, to say a few words before we proceed forward in this program.
Ma'am, please unmute.
A very good evening. As Secretary ISAR, I welcome Dr. Ibrahim to this prestigious series, which has got no frills, and we are not going to talk a lot. We just want academics here. So instead of wasting time, I request you to please go ahead with the program.
I request Dr. Erica to please introduce our speaker for today and take this program forward.
Thank you so much. It gives me a lot of happiness to I am inviting Dr. Ibrahim El-Khatib. He's the lab director for Art Fertility Clinics. He has done his PhD in reproductive genetics and completed his bachelor's in genetic engineering and biotechnology, MSc in healthcare management, MBA in data science, and MSc in IVF, biotech, and human-based research. He has an extensive work experience in the embryology lab. He's a lab director currently at Art Fertility Clinics, Abu Dhabi. He is an invited reviewer for many scientific journals, speaker at many conferences, and he has over 100 to 200 publications in his name. So without further delay, I invite Dr. Ibrahim El-Khatib. Today, he's going to talk to us about AI and morphokinetics in IVF lab. Over to you, Doctor.
Thank you very much for the kind introduction. Thank you, Dr. Asha, Dr. Amit, and Dr. Erica, and the organizing committee for inviting me to participate. And indeed, it's a very nice initiative, and it's always nice to contribute with esteemed colleagues discussing latest advancement that eventually will allow us to improve our results. And hopefully, this discussion continues in the future. The topic of today's presentation, I think it's a hot topic, not only in the field of reproductive medicine, but in general. The application of artificial intelligence is now widely, and in all aspects of our life, we're considering the the role of artificial intelligence. So why not to consider or to discuss how we can utilize artificial intelligence and other advancement in our field in order to improve our results. So let's start with what presents an IVF cycle. We all agree that in order to get a successful IVF cycle, we will need a collaborative effort between physicians and embryologists in every aspect of the IVF cycle. Now, this includes the ovarian stimulation, followed by whatever we do in the insemination, the embryo culture, eventually selecting the best embryo for a transfer. And then while the doctors are doing the endometrial preparation, we do the warming, and then hopefully we get eventually a live birth. Now, if we take a look over the past decade or two, the national reports of live birth, we all agree that we are at continuous improvement. So every year we are getting better results. And that is simply because of research. We understand more the infertility factors. We have better technologies. However, if you take a look, still today, national reports of live birth do not exceed 40 or 50%, which shows that there is still a lot to understand, a lot to comprehend, and eventually a lot to improve. Now, one of these things is embryo selection for a transfer. So if we take a look at these two examples, and this is a real case from our lab, this patient got these two embryos. If I ask the audience, which embryos would you select for a transfer, embryo A or B? For sure, we have limited information, and the only decision will be based on the morphology of these embryos. I think we all agree that most of us, if not all of us, we will select embryo A simply because it's more advanced, better expansion, better quality of trafectoderm and nasal mass. Now, these two embryos were subject to PGTA, and embryo A came out to be aneuploid, and B was euploid embryo. So we transferred embryo number B, it implanted and resulted in a healthy live birth. So clearly, morphology cannot be the only criteria that we use to select embryos for a transfer. This was extensively studied, and this is one of the publications showing that for female patients more than 38 years old, only 20% of excellent quality cleavage stage embryos are actually euploid and have the potential to result in a live birth. While even if you extend the culture to blastocyst, it's a 50-50 chance that you select the correct embryo. So clearly, we required more advanced, we required some tools in order to assist us, help us in our selection for embryo transfer. And luckily, over the past decade or two, there was a huge advancement in incubators. So the technology used behind these incubators, we all remember when we were dependent on large box incubators, we moved to benchtop incubators that they provide controlled conditions, faster recovery, hopefully better results. And nowadays we have the time-lapse technology that we can also use in our lab. Now let's talk about the time-lapse incubators as incubators. So it's a simple, basic incubator that provides gases, temperature, possibly other features like measuring pH. But with one important addition, there is a camera that takes a picture every specific period of time. It could be 5 minutes, 7 minutes, or 10 minutes. So imagine after 5 or 6 days of cultures, you will have hundreds of pictures that eventually you will be able to display as a video. And you will be able to do the annotation of the grading of these embryos without the need to take out these embryos out of the incubator. Now, this is a result of analysis for in one of the clinics in Spain, where they compared later. So they compared the agreement between embryologists when it comes to grading a blastocyst. And they found that the agreement between the embryologists when they were asked to do the grading for the blastocyst based on expansion, nasal mass, and trafectoderm quality was moderate to good at best. Now, when when they asked these embryologists to do that blastocyst or the embryo annotation based on morphokinetic points, they saw that the consensus or the agreement between these embryologists moved from moderate to very good. It means that simply by having these time-lapse incubators, you will increase the objectivity when it comes to grading these embryos. Now, again, we're talking about this time-lapse technology as an incubator. We said that you don't need to disturb the embryos by taking them out of the incubator to do the annotation. And so simply by avoiding the opening of this incubator, we would increase the quality of the embryos. This was demonstrated in this publication where they showed that the number of openings for the incubator is associated with the quality of blastocyst. The lower the number of openings, the higher the blastulation rate, and also the better the quality. Other studies, they have compared the same using these standard incubators compared to time-lapse incubators. And in this publication, they showed that euploid rate was significantly better. Good quality blastocyst was better. And in this publication of Alex and his team, they showed that you have better quality on day 3, and the quality of blastocyst was significantly better in time-lapse incubators compared to standard incubators. This is one interesting study. They randomized patients into time-lapse and the standard incubators, although they didn't see a difference in the quality or the blastulation rate, but they saw a significantly higher live birth rate in the embryos that were incubated or cultured in time-lapse incubators. So I think we all agree that as an incubator, it seems that this concept, it's working and it's beneficial. But the mere competency, the most important part of these incubators is not only as incubators, but is the amount of information that we get when we utilize such information. So since the introduction of time-lapse technology, a new, very important term in our field emerged, which is the morphokinetics. Morphokinetics is simply a time point and a cell division. So if we say T3, it's a morphokinetic point, which is referred to the time from 3 cells minus time at 2 cells. If I ask you, you can identify the time that it started compaction, the time of blastulation, expansion, name it, as long as it's time and embryo division or embryo behavior, this is referred to as morphokinetics. Now let's take a look at this video. We can see on the right corner of this video, there is the time. So you can clearly identify without the need to take out the incubators at exactly what time this embryo went to 2 cells or 4 cells. Now, after we start to apply this and follow up with these embryos, we notice some behavior of the embryos that we didn't know before. Why? Now imagine on day 2, you take out the embryo out of the incubator, you go to the microscope, you check, you found it was 3 cells, you would write down 3 cells at this time. Now, the next time you will check these embryos is after 24 hours. You will find that it's 5 cells, 7 cells, or 8 cells, right? Whatever happened between the 3-cell stage and the 8-cell stage, we have no clue. We don't know anything. So once we started following up with these videos, we learned a lot about embryo behavior that we didn't know that it exists. So if you take a look at this video, it went to 1 to 3 cells, went back to 2 cells, and then it was divided to 4 cells. So we could have easily missed this behavior, which is referred to as reverse cleavage. Why? Because it depends how lucky you are to check the number of cells or to do the grading for this embryo. This video to the right, we can see that at the 2-cell stage, there is multinucleation that disappeared at the following stages. Again, it depends on at which stage you will be able to grade these embryos and if you're lucky to notice this or not. I think this video will show blastocyst collapse. Unfortunately, not a very clear video, but you can see the concept that these behaviors could have been easily missed if we didn't grade at that time. So you can see now, we can see the starting of the compaction. The embryo starts to blastulate. It expands, then collapses, then expands again. Now, once we noticed or learned about these behaviors, we were very interested in knowing what is their predictive value, what is their effect on the reproductive outcome. So these are 2 of many studies that aimed to investigate or understand these behaviors. We can see in this paper that the prevalence of reverse cleavage is 27% in the cohort that were studied in this paper. And they found significantly lower implantation for embryos that they had this behavior, the reverse cleavage. Again, another study showing that multinucleation at the 2-cell stage or the 4-cell stage would result in decreased implantation, and so on. So this is a review, very nice article, showing several behaviors, what's their prevalence, and also what is their impact on the reproductive outcome, have it live birth or implantation. In this study by Barry in 2017, they did something very interesting. So they used the time lapse, they transferred embryos, and then after they transferred the embryos, they went back to the videos and they identified the embryos with abnormal behavior or abnormal division compared to the one with the normal division. And they checked the implantation. And they saw that embryos with abnormal division had only 7% implantation compared to 39% for embryos with normal implantation. So imagine how useful and powerful is this tool, just identifying abnormal embryo behaviors. So this is a study by the group of Marcus Messiger. What they did is they randomized patients. They selected in one group embryos based on morphology only, the other group based on time lapse. And they found that the group where they cultured the embryos and selected the embryos based on time lapse, they had significantly higher ongoing pregnancy rate, they had significantly higher implantation, and significantly lower miscarriage rate. This is another study by the same group in collaboration with the group of Laura Rienzi. They said, we have all these details, we have all these morphokinetics points, let's see, and we know what was the outcome of transfer. Let's see if we can identify specific markers, specific morphokinetic points that would predict live birth. And they found in their study that time of morulation, time of compaction, the lower it is, the better, and also the quality of trophectoderm. So now how we can apply this in the lab? Tomorrow, if you have 2 embryos to select for a patient, you have the time-lapse videos. You can identify, for example, at which stage this embryo was compacted, and then give preference or priority to the embryo with a time of morulation within this range explained in this study. So, of course, that was not enough for us. We were greedy and we said, okay, what if through morphokinetics, we can predict the chromosomal content? We can identify the euploid embryos or identify the aneuploid embryos in order not to transfer them. So this in 2013, the group of Alison Campbell, what they did is they collected the data and they created this small model that will give a rating for the embryos on their chances of being euploid or aneuploid. So it is divided into low, medium, or high. Okay, we can see low, medium, or high. And then in the following year, they attempted to validate their model, and it showed within their database that it was working very well. So they started to select the embryos for a transfer based on these 3 classes, and it was working well. The same year, a group from New York, they said, okay, we want to use the same model. So they used the same model with their patients, but unfortunately, it was not working. So simply they said, look, we applied. It was 2 publications, but when we applied this model, it was not working with our patients. Another attempt, and this is a nice example to understand why it doesn't work for everyone. This is Natalia Baselli group. Again, they have created a model that will give a grading A, B, C, D, A highest chances of being euploid. It was working well with their data. The group of Rienzi attempted to validate this model, and they found that it was not working. In fact, in their database and with their patients, they identified different markers than the ones Natalia Baselli found. And the simple explanation for that was, in the study of Baselli, they were doing the biopsy on day 3. In the study of Rienzi, they were doing the biopsy on day 5. So we can see just one simple difference in the protocol unvalidated the whole model. There were several attempts to replace PGTA with morphokinetics. This is a review, and clearly the conclusion is morphokinetics cannot replace PGTA, traditional PGTA. There is different reasons. First of all, these models include different populations. So not necessarily a model that it was created in Abu Dhabi, for example, with the population we are treating could be useful or applicable in India, for example. The same, if you create a model in Germany, not necessarily it will be applied on a population that is in Africa. The second thing is day of biopsy. We've seen that was explained in Rienzi and Basili's paper. Sample sizes were in some of these models were created using relatively low sample sizes. And of course, it is always done in a retrospective design. This was again published and explained all of these factors in a paper by the Ishri group. And they said they added to that one explanation could be not only the patient population, patient age, the type of infertility, reason of infertility, the stimulation protocols, the protocols in the lab, and so on. There are other studies that they have discussed, and what was the conclusion is that not necessarily we can use morphokinetics to replace PGTA, but maybe we can compare. There were several studies comparing selecting euploid embryos based on morphology or based on morphokinetics. And most of them, they showed that selecting euploid embryos and using morphokinetics is better than using morphology. So clearly, we have a lot of data, right? So we are happy with this time lapse as an incubator. We are utilizing the information we are getting, but at a certain point, the amount of information that we had became too much. And here we started to understand or to appreciate the role of artificial intelligence, machine learning in utilizing this big data. Just if you think about the amount of data in the IVF lab only, that could contribute or influence or have an impact on the final outcome, which is live birth or implantation. Many. It's the type of culture media, the pH, the method of insemination, and you're doing group culture, single culture. What time do you do the ICSI? With PGTA, without PGTA, which PGTA methodology are you using, the humidity level, the type of incubator, mixed gas, dry gas, and so on. So there are so many factors. All of them could explain why a model works in my lab, doesn't work in your lab. Add to this information patient-related information, the patient age, the AMH, the ethnicity, the etiology behind the infertility, and so on. Add stimulation information. We're doing agonist, antagonist. We're giving this type of trigger at this size of follicle, and so on. So you can imagine the amount of information that we can utilize in order really to be able to create this universal model that will help us. So, and this is exactly what machine learning or artificial intelligence is meant for. So we use artificial intelligence nowadays in any field, either for classification or assessment. We use it for prediction. We want to create predictive models utilizing information. We want to automation, and we can see that in several applications, not only in the field of reproductive medicine, but in other fields of medicine or other industrial fields. And one of the examples that is, for me, a very nice example of how we can incorporate artificial intelligence and machine learning in the lab is this paper. So what they did here, remember we said morphokinetics is very important, but it depends on me as an embryologist or operator to select the times. This group, they created an automated tool that will do the annotation of morphokinetics. So the first very important advantage of this is objectivity. So if you have an automated tool, then it will be consistent across all the embryos when they do the annotation, not like me before lunch and after lunch. The second very important thing, the amount of time it saves the embryologist. And they did very nice calculation. Let's say that each embryo takes 3 minutes to do the annotation. And you have 20, 30 embryos. If you calculate per year how much time you spent in order to do these annotations, they will add up to a 1 month, what is worth 1 month of an embryologist. So it will save you time and it will save you money. Another very interesting utilization or application of artificial intelligence is image analysis. Now, we humans, we tend to get limited number of data when we look at the picture. So if I give you a picture of a blastocyst, we will maybe give grading for the NSL mass, trophectoderm, the expansion, maybe granulation or if there are separated cells. But if you get a software, a machine that will do the analysis, you will get so many, you will get, different time points, different focal planes, you have segmentations, you have the contrast. The amount of data you get is tremendous. So we started to utilize this image analysis in order to see if we will be able to utilize any information that we embryologists don't have. And this is one of my favorite studies because they explained it in a way that we understand the value of such tool. So what they created a machine that will be able, a software that will be able to give grading for the blastocyst. It will tell you this is the grade of inner cell mass, trophectoderm, and the expansion based on 4 categories: good, poor, fair, or uncertain. What is interesting for me is this graph. So as I told you, good is yellow, poor is blue, fair is gray, and brown is uncertain. And they asked 5 embryologists to grade the same number of embryos. So if you take a look, you see it's a technicolor, you have all the colors. So we selected the 4 categories, and it doesn't look that we are completely consistent when it comes to the grading. And then they asked the software to do the grading for the same embryos. Take a look at this line. The first line represents the software. It had only 2 categories, good or poor. There was no uncertainty, no fair grading for embryos. Why? Because it's a very objective tool. It was fed data, it identified the relationship between this data, and it's applying it for every embryo. There is no bias. Human beings, on the other hand, we tend to be a little bit emotional when we take our decisions. We love to be in the middle. So instead of good or poor, look, these are 2 extremes. I want to be in the middle. So we utilize fair a lot. What is also interesting, they also measured the majority of the votes of these embryologists, which is the second line. And they compared these results to each one of these embryologists and also to the software. And they found that majority of votes of these embryologists was the closest to the software than any of these embryologists. So now we can understand why we need such tool in the lab. This is another very interesting study that they created this tool that will be able to identify blastocysts as high chance of live birth, low chance of live birth. If we take a look at the example of blastocysts that they were graded high as per this AI tool, we can see, I think, that most of them, indeed, they look very good. But if you take a look at the blastocysts that they were graded as low chance of being live birth, some of them are relatively good. Me as embryologist, we don't see a lot of difference between these 2 and these 2, for example. So the question is, what did the AI tool see and we didn't see? And the author explained that this tool identified specific cluster or pattern of granulation or clustering in the trophectoderm that was associated with lower implantation. That's why we embryologists, or human beings could easily miss these patterns. But with an AI tool that will do the segmentation, it will be very subjective and can identify such tools. This study got a lot of attention for one reason, that the area under the curve was more than 0.9, which is rare to have in our field. And what they explained, what they demonstrated is a deep learning tool that will be able to predict fetal heartbeat. This is based on morphology and morphokinetics points. And since then, there were several applications. We have, I think, one oral presentation this year at ISHRE explaining an artificial intelligence tool that will be able to take information from videos of embryo division and will be able to, at any certain point during the division, predict with a high accuracy if this will result in a blastocyst or not, and if this blastocyst will be euploid or not. This is an application of artificial intelligence in sperm selection. I was, lucky to work with the owner of this company also, so we had very interesting discussions, and I think this is a very interesting tool. So what it does, while you're doing the ICSI, this software will tell you which sperm cells has higher chances of fertilization. So it's live. It's while you're doing the selection, it will indicate which sperm you should select. And on the right, we see this. It's not clinically applied, but they call the robotic ICSI. So it's a robotic tool that will be able to take the sperm and deliver it to the oocyte. So imagine in the near future, if we can apply such a very objective tool to select the sperm that gives the highest chances of fertilization with a tool that will, again, without any intra or inter-operator variability, perform the injection. And this is a tool that is expecting the robotic sperm delivery. It's will be extremely important in cases of severe OET, cryptosample, testicular, where it's very difficult to find sperm. Again, the limit is the sky. So the concept of machine learning, as we said, is to analyze big data. And this for me was very interesting idea that I feel silly how we didn't come up with this idea. So we know that if you're a good lab, you need to check your KPIs every month. But the thing is, let's say that this month I did the KPIs. I went through KPIs of the month of May, and I saw that we have low blastulation. So I investigated and I found that this batch of media was not good. Let's say, for example, the media was not good. So what I will do, I will change the batch of media. Very good. So I started 1st of May using this batch of media. I identified the outcome 1st week of June. It took me a few days to make the order or to identify. It means that for 6 weeks, my results went down because of something that happened 1st of May. So in this paper, what they said, give us all your data. We will identify a pattern. Of course, we don't know what is this pattern. We will put all this information and it will give you an alarm. So instead of waiting till 2nd week of June or 1st week of June to identify that mistake, you will get an alarm 1st week of May to say, look, based on this pattern, it looks like you have a problem with the media. And then instead of fixing this issue after 6 weeks or 4 weeks, you will be able to correct it after 10 days or 7 days. This is a very interesting application for me for artificial intelligence and machine learning and in general, let's say, analyzing big data. So we can, give example of 50 other studies. Mainly, most of the studies aim to predict live birth, to select embryos, to assess us in more objective grading, save us some time. We've seen an example how to select embryo, how to select the sperm for injection. We have a tool also now. I think it will be commercially available very soon that will be able, just by putting an image of the oocytes, will give you chances of this becoming a blastocyst. And I think this is helpful in India, considering the recent law for donors that you can select only 7 oocytes. So imagine you get from a donor 20 oocytes, you can only choose 7. So if you have a tool that will tell you out of these 20, which are the 7 oocytes with the highest chances of fertilization and blastulation, I think this will be useful. So the application is mainly things that utilize information at early stage, like day 2 or day 3 information, morphokinetic points early stage, or it could be at the blastocyst stage or the full division, for example, from the moment you do the insemination until it reaches blastocyst. In general, the concept is the same, and I think maybe we cannot rely completely on them today. However, it is very useful and it looks like it's very promising. So in the next part of my presentation, I want to answer why we cannot rely 100% on AI today. So the first thing is bias in the data sets. And I will give 2 examples, are not from our field. So this is a tool that was developed, a neural network model that will be able, just by giving skin picture, identify melanoma. So this was done using pictures from patients in Germany, 2 or 3 universities. They collaborated and they came up with this tool. Do you think if I take this tool, I go to India or I go to Africa or I come to GCC and I put pictures of patients with darker skin, do you think it will give the same prediction it gave for the German patients with the white skin? The answer is no. And this is what happened. Now, every time they got a darker skin patient, the chances of having cancer was much higher. Why? Simply because the data that was fed to create this model was dependent on a specific population. Another example is this machine tool that aimed to predict cancer in some patients using X-rays. So this, they noticed after they tried to apply this tool that there was one department in one hospital that was continuously getting higher chances of cancer for their patients than another clinic. And the explanation was simply because that department has the biggest oncology department, and their MRI machine, they give a different background than the other clinic. So whenever the software gets an X-ray image with a darker background, it identified this as a marker for having cancer. So we need to be very clear about which type of data set was used. Will it work for me or not? Especially if everything was done by another group in a different population. And specifically in our field, in the field of reproductive medicine, this is very sensitive and very important. Our group published several papers about the socio-cultural influences, the ethnicity influence on infertility. I think we all agree that the infertility factors in India are different than in Europe, are different than GCC, are different in Africa. There is an effect of culture, the DNA, our genes, the life habits, and so on. So we cannot simply blindly replicate whatever is worked, whatever is published or created by other groups, because simply we don't know if their population represent our population. Another very important reason for all of this is, if you create a model that will give you chances of a blastocyst, you need to take in consideration that this tool will not be able to differentiate between a static image or a dynamic image. Is the background dark or not? I'm working with one university in Turkey on a machine learning model, and we exchange some of these blastocyst images, and they found that the application or the software that we have created is relatively accurate with our images compared to the other images. And the explanation was the quality of the camera that they used to take the images was different than ours. It was an older type of camera, but unfortunately, the machine doesn't understand all of this. The tool that we are creating doesn't understand the difference between all of these things and might mislead us with the conclusion. That's why it's our responsibility to be able to identify what works and what is the reason for this discrepancy. This is a very nice example of input data, how important it is. So this was presented in ISHRE. They created a tool that will select embryos for transfer. So you give embryoscope images, and it will tell you embryo number 5 has the highest chances of live birth. They noticed that the software is favoring embryos that are cultured in wells 1 to 5. What is your explanation for that? Now, if I ask the audience, and maybe you can put your answer in the chat if possible. If you have an AA quality embryo, excellent quality in well number 1, and you have the same embryo, the same quality in number 12, and you need to select one embryo, would you choose number 1 or number 12? So when I asked my colleague which one you will choose, they said, look, logically, we are human beings. I will start from the beginning. So I will start with embryo number 1. So because this information was fed to the machine model, to the model itself, it identified as being in the first wells increases your chances of live birth, while this is not correct. So where are we going? We cannot give up on artificial intelligence. It's very promising. And we've heard, all of us, about the concept of IVF lab on a chip. And I can tell you that there is a lot of advancement when it comes to this. Yes, we will have an automated tool. We will utilize technologies like microfluidics in order to automation for denudation, for example. We've seen the automation for ICSI will be in the near future. We will have machine learning models that will be able to analyze all this information, whether it was about the embryo division, about the patient, the stimulation, metabolomics, all of these things, and will give us simply a very nice suggestion of an embryo that we will transfer so that we increase the chances of pregnancy. So to summarize, time-lapse incubators, they provide controlled culture conditions. Time-lapse can improve embryo selection for transfer by utilizing morphokinetic information. Automated grading can reduce time and increases the objectivity in our selection. The application of AI in the field of reproductive medicine can improve and will improve clinical outcomes. The question remains, can we implement it today? Thank you very much.
Thank you so much, Dr. Ibrahim, for this was an excellent eye opener as well for us. There are a lot of things that we didn't even know existed or are in the pipeline of making, especially the ones where you talk about how we can pick up something going wrong with the media immediately. So, how many of these do you use in your lab? Like, what all have you implemented?
So for now, we have 2 papers now under review. One of them is we created a model called the growth variance. So instead of doing what was done in the morphokinetics to specify specific time points, we have identified a specific pattern in all the embryo development that will be able to give chances of the embryo of implanting. And when we applied this tool to our previous data, we saw that it was consistent. It was giving really higher grade for the embryos that resulted in live birth compared to the one that they didn't. And I think such a tool is extremely important. Do I think that this will be replaceable in another clinic in India? Maybe not, because we explained the reason, right? Maybe they are doing the ICSI at different time. Maybe they are using different cultural media. Maybe yes, maybe yes. But why we wanted to publish this paper, we didn't think of commercializing something like this, because this will inspire other groups how to utilize their data in order to create a tool that is tailored for their population, for their protocols, for their lab. Another paper I told you, I think you know, Dr. Raquel de Loja, Galigo. She is presenting in ISHRE this year. A very interesting AI tool. It was done in collaboration with New York University. I think this is something very important. We have another paper now under review. We utilized information of day 3 that predicts with high accuracy, relatively higher accuracy, the potential of blastulation for these embryos and being euploid embryos. So I think these are simple tools that are useful. With the university in Turkey, we are working on utilizing a tool that will do segmentation for images and will be able to automatically identify where is inner cell mass trophectoderm, hoping that this will allow us to identify the best time to do biopsy for a blastocyst in PGTA or PGTM cases. And all of this is how we call it stop points in order to get our ultimate goal. And this is what we're collaborating with the university to do. We wanted a tool that will include patient information, lab information, and eventually stimulation information, in a sense that if I put details, specific details of a patient, it will even identify which stimulation is the best, which dose shall we start, at which stage we should trigger for this patient, if we should use IX and IVF. Of course, this requires we start by a tool that will be able to identify the best time for biopsy, a tool will be able to predict blastulation, and then we will add the clinical data in order to get such a tool.
So, but you still recommend that when these tools are made or the formats are made, it would still be better if we do it with an Indian population and an Indian data set versus just picking up something.
Look, ideally, I believe, yes, this will be, the best, but not all of us, we have the resources to replicate or to do all of these things. So I don't expect that each one of us, we will have our AI tool. Just whenever we want to use any of these tools, we need to keep an open mind on why it can work with us and why it can not work for us. I think this is the take-home message. Be careful. It's not to give up on these tools, no, but simply validate it yourself with your data. So if you got, for example, if you got a tool, let's say that will select embryos for transfer. First validate it. So you randomize patients, you do some patients, you select like the way you used to select using this tool. If you see it's working with you, it means it's working for you, right? But you cannot just blindly utilize this tool for all your patients without validating if it will work for you or not.
I have one last question. What, according to you, are the best sperm selection tools?
Well, I think, Dr. Erica, you know me. I support the women, so I believe that they can take the lead. They can correct a lot for mistakes in the sperm. So always my attention is more to the oocytes, the stimulation, than the sperm. I think there are relatively good amount of tools that if they are not providing a lot of benefit, at least there is science behind it and it will not harm, like using these MAX, microfluidics technology. I think MC, some patients that would benefit from that. Large RCTs didn't show benefit for using MC, which magnifies the sperm more and to be able to identify miscarriages, a sperm that will lead to miscarriages. DNA fragmentation, there is a lot of attention on it. So it could be, if we have patients with high DNA fragmentation, you use the MAX technology or use the microfluidics, it could be better. I like this STED. I think it's a very nice tool that will identify the sperm based on their motility and the pattern of moving. Yeah, so for me, so far, I'm depending on my eyes and the microscope, so not a lot of fancy things for selecting the sperm.
Thank you.
Abraham, can I ask you a question? Fantastic talk and very, very stimulating to the mind. As a clinician, these techniques will help to reduce time to pregnancy because you will choose the best one. What happens if your patient doesn't conceive with this embryo? Would you be counseling the patient to use the other embryos, knowing that the pregnancy rate is going to be low? Because that indirectly affects your clinic success rate also. And in countries where you're ranked according to your success rates, you may not be comfortable using these embryos.
Thank you, doctor. I lost part of the question. So if I understood correct.
Yeah. My question to you is that using these techniques will reduce time to pregnancy. That is
perfect. That's doctor. That's the best explanation for that. Indeed, time to pregnancy, that is the ultimate goal, because these are not therapeutic tools. These are not therapeutic tools. They will not change the ultimate destination or destiny of this embryo, but indeed it will reduce the time to pregnancy. But doctor, often when we talk about this, there is one very important factor that we oversee, which is And this is mainly in the debate of PGTA and such tools. I understand that we say, okay, we have 5 embryos, so no need to spend more money to utilize a tool that will select this one embryo that will result in a live birth, for example. We can do transfer. If it's not successful, next month, the other. That's correct. But doctor, there was a study by a Chinese group for 70,000 women. 70,000 women, 35,000 of them, they had previous miscarriages, whether it through IVF or without IVF, and 35, they never had miscarriages. And they found that the patient who had miscarriages, even if it was because of natural conception, they had significantly lower chances of getting pregnancy naturally after that. They had higher chances of inflammation and infections. It means that also we have responsibility, ethical responsibility towards our patients, not to think about any negative cycle as only a negative cycle. It's not statistics anymore. This is a person who will go through all the stress to do the blood test, and you will tell her, you know what, you're not pregnant, let's repeat the endometrial preparation again. You're not pregnant, then to get pregnant. Or if she gets pregnant and she miscarried, again, we're putting her at risk. So any tool, as you correctly mentioned, will help us to reduce the time to pregnancy, will support that patient psychologically, and also will reduce any unnecessary adverse events that you can go through.
Absolutely. I mean, that's not my question. My question is, in case a person doesn't conceive with this embryo, now you have the other embryos which you know are suboptimal. How do you counsel your patient to use those embryos, given that the first embryo has not achieved a pregnancy? Second, in some countries where you are ranked according to your success rates, how do you manage that as a clinician?
All right. So I think having these tools will support the notion of ranking our results, right? If I have a tool that will allow me to have even another information to utilize the embryo with the highest chances, then I should use it, then it should work better for us. Now, I agree with you. Sometimes embryos, they have an AA embryo and a CC embryo. Of course, we transferred the AA, she didn't get pregnant. Now, their chances with the CC are statistically lower than the AA, right? But they are not zero. So we are obliged to go through such a transfer to perform the transfer. Will it affect the results? It could be. Honestly, yes, it could be. But we had also cases where lower quality embryo, but at the end, it ended up being, resulting in a live birth. This was my second or third slide. 2 embryos, one of them was much better than the other, and eventually she got pregnant with the second lower quality embryo. How do we counsel our patient? Honestly, all of these slides, what I presented today, if I will utilize any of these tools, this is the first thing I will show the patient so that they understand that what our decision is evidence-based decision. So we utilize science, we utilize what is published, and then that's why we took our decision. It is not a guarantee of 100%, of course, and we need to limit their expectations with the second trial of the embryos. Some of our patients, for example, they say, no, I don't want to go with the second embryo, I want to try another cycle. That is on them. But we provide all of this information, especially if I will utilize such a tool. And in most of these applications, what we do, we are performing a study. And so all of this information is even explained to the patient prior to starting even the stimulation.
Thank you.
Thank you very much, Dr. Ibrahim, for such a good talk and taking us to the high-tech technology. But I was just wondering that if you were left with an ordinary lab where there was no time lapse and all those things, would you be happy still working, or now you feel that no, this is how every lab should have?
No, as long as you will find me another topic to present, I don't mind. Okay, but don't give up on me. So, of course, we've been in the days where we didn't have time lapse, we used simple technologies, but of course, we can see the effect. I think, doctor, if you see this chart, I really like that chart of the live birth rate. If you see in 2000, if you had 40% pregnancy rate 10 years ago, you would be the happiest doctor. Now, if you have 40% pregnancy rate, you will put an alarm in your clinic, right? You will not be satisfied with these results. So I think we utilize these technologies properly. I mean, and the reason, honestly, our life yet didn't come easier. It's not easier. Actually, it's more information. The old days of simply doing ICSI, transferring day 3, day 4, day 5, no PGTA, no NGS, no effect of mosaicism, or laser, or all of these analysis. It was simple. But I think these days, I mean, we can differentiate ourselves with the knowledge that we have, with the technologies. It's not necessarily that you need to have the most advanced IVF lab, for example, to have the best results. As long as you have the base, you take a decision based on science, utilize whatever you can. And I always say that our responsibility is to utilize, to make the best out of the resources we have, not the resources that we don't have. I don't have time lapse, then I need to find a way in order to select the embryos. I tell you something, for example, in University of Brussels, before time lapse, they analyzed their data and they found that if the embryo is at the 5-cell stage between 34 and 36 hours post-insemination, these embryos, they have the lowest implantation. That's not time lapse. They didn't have time lapse. But that required that instead of checking the embryos on day 3, they started to check embryos on day 2, right? So instead of checking on day 3, they check on day 2 to identify this range. So regardless of the time, the resources, we are now obliged to make the best out of them. So we need to create such a tool that works well for us.
Thanks. That was nice. So basically, the time lapse is a very good incubator. At the same time, it helps us in selecting the embryos and combining it with AI, it will really help us select a very good embryo and definitely will help us improve the results. So thanks a lot.
Thank you.
Thank you so much. Thank you so much, Dr. Ibrahim, for
Are there any
really
questions on the
stimulating.
chat or anything, Erika?
No, ma'am, I finished all of them, ma'am. I would request Dr. Asha to give a vote of thanks.
So thank you very much. And I would like to thank Erika, Dr. Ritu, and of course, our president, Dr. Amit Patki, for starting this series and taking all the efforts and selecting such good speakers. And people really look forward the moment we say that Soliloquy series is coming and people are really, yes, we are going to go for it. So, and the viewership is really good, and keep doing the good work, and I'm sure we'll learn more and more. And we would like to see you again, Dr. Ibrahim, sometimes again for our other webinars.
It will be my pleasure. Thank you very much again for the invitation, and congratulations on this successful meeting.
Thank you.
Thank you so much. Thank you. Good night.
Thank you so much, doctors. I will now be ending the meeting. Thank you for attending.